Hi, everybody, and welcome to our webinar. Great to see some familiar names here on the list. And yeah, looking forward to a great discussion and a great talk today. Hi, Paul. I guess it's good afternoon for you, or good morning. You're in the East Coast, I believe, correct?
Yeah, it's about 2 p.m. here on the East Coast. It's good to be here.
Yeah, good to be here as well. So I'll show you guys. We'll get started in just a minute or two. All right. So test drive. Paul, do you see the screen?
Yes.
Great. Okay, so hopefully everybody else does. So welcome. This is another RSIP Vision webinar. Today we have Dr. Paul Yee, Director of the Medical Intelligent Imaging Center at University of Maryland. Paul has basically started up this interdisciplinary research center at the intersection of radiology and AI, with a strong focus in musculoskeletal imaging, which will be the focus of today's talk. So a lot of you invitees are, from the orthopedic community, but not only. Paul Center is actually was founded or christened, so to speak, in September. So the new interdisciplinary group doing some very exciting research. And he'll talk about pitfalls in deep learning for MSK imaging and opportunities for improvement. Before we get started, I'll just introduce our company, a brief minute or two. So we're RSIP Vision. We develop visual intelligence software solutions for medtech. So, AI is said way too much these days, but we basically create software modules that analyze medical images and enable improved surgical planning, navigation, and analytics. On the planning side, it can be elevating X-rays and creating 3D models, or elevating MRIs and producing upsampled models, or quantifying things like soft tissue in MRIs. On the guidance side, things like virtual measurements in surgical procedures, guidance and quality feedback and measurements for ultrasound and analytics. We work with the medtech industry, as Paul and I were chatting. We're, as a company, focused more on the medical device industry. We have solutions that are deployed and been used in thousands of clinical procedures together with our industry partners. And we're holding these webinars, first of all, just as a service to the community, but also in order to learn from the research that's being done in the academic world. There's obviously no substitute for this, and really to be up to date and to see how groups such as Paul's, consisting of both the radiologists and computer vision researchers and people who have spent their whole careers basically at the intersection of these two fields, are dealing with the real clinical challenges, right? So not just how to publish a nice paper, or how to solve a cool computer vision problem, but what happens when we actually try to take these technologies and put them into clinical practice. What type of pitfalls do we have? How can we ensure that our solutions are will work the way they want in the real world, are generalizing, are not biased, and where are the opportunities for improvement? And with that said, without further ado, I will turn this over to you, Paul. Here we go.
All right.
One more word. So, everybody in the audience, you're free to type in your questions. There's this questions box in the UI, and towards the end of the talk, we'll pass on some of the questions to the speaker. We can have a brief discussion at the end. All right.
All right. I'm actually trying to share screen. Okay, there we go.
Now you should get it.
All right. Well, Moshe, first, thank you so much for the opportunity to speak with you and everyone else here on the webinar. It's a real pleasure to be here. I think the work you all are doing is really amazing. And so, yeah, with that, the title of my talk today is Can We Trust AI? Pitfalls of Deep Learning in Musculoskeletal Imaging and Opportunities for Improvement. As Moshe said, I am the director of the UME Center, or University of Maryland Medical Intelligent Imaging at the School of Medicine, where I'm in the Department of Diagnostic Radiology. I'm also adjunct faculty at Johns Hopkins at the Malone Center for Engineering and Healthcare. The following are my disclosures, and here's my face if you can't see the video. We do work with a number of companies that fund some of the work, some of the research grants here. I'm involved with a number of other groups, as we'll talk about. And so the outline today, we'll start with an introduction and specifically one radiologist's point of view about AI. We'll move on to potential pitfalls of AI in MSK imaging, and then finally end with considerations for the practicing radiologist, surgeon, or other physician. So by way of introduction, I just want to tell you a little bit about myself. So I'm a radiologist, but between the years of 2004 and 2016, I thought I would be an orthopedic surgeon. I know a lot of you are in the orthopedic industry, and so I basically entered college and medical school thinking I'd become an orthopedic surgeon. During medical school, I spent a year out doing a gap research here at Rush University Medical Center, working with Dr. Craig Della Valle, where we did a lot of work looking at infection and other complications after hip and knee replacements. I was fortunate enough to be involved with work like this, diagnosing infection in the early post-op period after total hip replacements, as well as in the setting of metal on metal bearings or corrosion. And this was really formative for me because it showed me how research wasn't just something that was fun, that was kind of a nerdy thing to do, but something that could really impact patient care. And that's really been my motivator going forward, even as I moved into radiology. So basically, I did a couple years of orthopedics residency at UCSF before I realized surgery wasn't for me. I had to do a lot of soul searching, and I realized that I still liked anatomy. I liked thinking about the musculoskeletal system, and I liked research. So I moved into radiology in 2016, and that's where I've been basically since. Just a brief background in my life in radiology. So my second year of residency in 2017, I had an idea about starting an AI research group. I started learning about it. It was about the time when our first papers in our field were starting to come out, and it just seemed really fascinating. So we started this group called RAIL, or the Radiology AI Lab. We connected with engineers across at the engineering campus at Johns Hopkins, where I did my training. And really, this was just like a motley crew of a couple radiologists trying to do some cool research. Well, that turned into presenting research at conferences like the Society for Imaging Informatics and Medicine, or SIM, and just getting more involved, learning more about the field. As I got more interested in AI, I realized that AI wouldn't exist in a vacuum, but really had to exist in a larger informatics infrastructure. And so I went over to the University of Maryland to complete an imaging informatics fellowship during my last year of residency. I was also fortunate enough to be part of the trainee editorial board, the inaugural class for the RSNA's Radiology AI journal. And that led to further opportunities with the RSNA, serving on the machine learning steering subcommittee and working with a number of companies and startups, including Bunker Hill and Amazon. And that leads me to today, where I've been recruited over the past year to University of Maryland School of Medicine to direct this new AI center called UMI. This is my team here. I'm the director. Our technical director is Dr. Vishwa Parekh. He's a computer scientist who's worked at the intersection of deep learning and radiology and medical imaging for the past 10 plus years. Dr. Peter Kamel is our clinical director, a neuroradiologist and really software guru. Our senior advisor, Dr. Elliot Siegel, who is a pioneer in imaging informatics, starting with the first filmless radiology department that he founded back in the 1990s at the Baltimore VA, to countless other developments in medical imaging. And our vice chair of informatics, Dr. Jean Judy, who I work with very closely in multiple fronts, from research to clinical. So with that, I want to move away from my background and talk about AI and radiology. So like most fields, interest in AI has exploded over the past 5 years, literally an exponential increase in the number of publications in our field related to AI and radiology. And so I want to ask the audience a question. How do you feel when you hear the word AI? Just think about it for a moment or two. All right, so I'm gonna guess some of you feel like this, super excited. You know, you've seen what it can do for Tesla, you've seen what it can do for your iPhones, and you're thinking this is gonna make our lives so much easier, whether we're a radiologist or orthopedic surgeon or some other type of professional. But maybe some of you are worried. You know, we've seen some of the pitfalls of things like self-driving cars. They don't work as we expect. And if we think about the potential to do harm for human health, well, that might make you nervous. And some of you might be a little bit more skeptical, just thinking, you know, maybe this stuff works in some settings, maybe it doesn't. And maybe some of you are just curious, you know, this AI stuff seems pretty cool, you're not sure what to make of it. I think regardless of where you are on that spectrum, these are all very reasonable responses. This was a word cloud of the top 25 non-scientific search results when you search radiology and AI in Google. And here we see a dichotomy of words, some that are very positive, things like coming, happens, future, very dynamic. But then you have some other words on the other end of the spectrum that are more cautionary, things like replace, judgment, hype. And so I think that it's normal to feel these things, but I think regardless of where you are, it's clear that AI is having a big impact and splash in our fields. And so what do I think? Well, I believe that AI will change radiology, but won't replace radiologists. And I think by extension, you could put in surgery and surgeons, you could put in physicians and medicine. And I think that, this technology has a lot of potential, but I think there's a lot of things that need to be worked out before it could ever replace a physician, which will be the topic of the rest of the talk. And so with that, the rest of this talk, looking at pitfalls of deep learning in musculoskeletal imaging, are from these three perspectives. The first is as a radiologist. First and foremost, I'm a physician. Even stemming from my orthopedic background, my motivation in all of this is to improve patient care and to improve human health. Second is as an outsider of sorts. You'll notice that I wasn't an engineer by training. I didn't study computer science. And so I really came into AI looking at it sort of like a curious person, thinking, how can this be applied to medicine? How can I apply my experiences in research to this? And then finally, as a collaborator, I've been really fortunate and blessed to work with so many smart people who have skills and knowledge that I don't. And I think that's made all the difference in allowing for really the sum of our efforts being greater than the sum of its parts. All right, so with that, we're going to move on to potential pitfalls of AI in MSK imaging. So we'll start with data sets because these are foundational for training AI models. People say data is the new oil. And so I think that it's important to evaluate what are some of the pitfalls with the foundations of AI. And so I want to talk about data set curation. This is a public data set of chest x-rays that's really caused a big impact in our field. It's called chest x-ray 8, now called chest x-ray 14. And this was the first large-scale data set of chest x-rays that was released back in 2017 by the NIH. And what's exciting is these were 112,000 frontal chest x-rays. Prior to this, we really didn't have large data sets available to train these deep learning models. Now, one thing to note here is that these are supposed to all be frontal chest x-rays. These are x-rays taken basically looking straight at the patient. And you would think that this is something that should be easy enough to catalog. When we look here, this is a frontal chest x-ray. This is not a frontal. It's a pretty obvious difference. And it's one of those things that should be as simple as saying right and left. And it should be easy to document. But when we look at the data set, there's actually quite a few non-frontal chest x-rays. We have laterals, we've got abdominal x-rays, we've also got some bones x-rays of the skull and pelvis. And this is all to say that metadata, which is the data associated with these images, and natural language processing, which is often used to extract labels, is not 100% accurate. So you can imagine that if we're intending to train a model on, let's say, frontal chest x-rays, but we've got a bunch of non-frontals, that's going to affect the quality of our model. So I think it's important to recognize that even our data sets, we can't take even the basic things necessarily for granted. And so you can imagine, even if we can't get radiographic views right, what about the disease labels, which is a much more complex problem? And so when people have looked at these large-scale imaging data sets, for instance, in the MIRROR data set, which is a set of upper extremity x-rays, when they look at the actual diagnostic accuracy, we see that the sensitivity is as low as 60% for degenerative disease. And so, again, the adage of garbage in, garbage out plays here, where if you have poor quality data without good labels, your model is probably not going to perform as expected. We did a slightly different analysis of the same data set in MIRA, as well as LIRA, which is a lower extremity data set. And we did a clinical audit, basically evaluating how good are these images from a quality standpoint for clinical use. Well, we found a number of problems. So for example, in the LIRA data set, there are multiple duplicate images with inverted pixels. So you can imagine if you're trying to train a model to look at normal x-rays and you have inverted pixels, you're probably going to get the opposite type of diagnosis or interpretation. And then there's a slew of other quality issues, montages of multiple views versus single views, fluoroscopy images, which really shouldn't belong here, but they were nonetheless included, and overexposed and underexposed images, which can all contribute to models that it might perform suboptimally. So I think that this all points to some pitfalls that data, even if we are able to automatically query a bunch of images, get labels in an automated way, we really do need to do our due diligence and actually look at them ourselves and confirm it clinically. All right, so moving to something a little bit more clinical, lack of robustness to clinical variations. So what I mean by this is that in real life, images are not perfect. In fact, they're far from it. There's a whole slew of different technical and practical limitations that we'll discuss in a moment that can really affect how an AI model performs. And so some of you might be familiar with the concept of bone age. This is for kids who are growing, basically saying, how old does this child's hand look? And the idea is, hey, you're 6 years old, your kid's hand is a 5-year-old kind of age. Well, they're probably a little bit behind the growth curve. And endocrinologists and orthopedic surgeons use this to predict how much growth potential does a child have to guide treatments for different diseases and injuries. And so this task was the use case for the first AI challenge put on by the Radiological Society of North America, or RSNA. And basically, this was a worldwide challenge asking people to develop algorithms to predict bone age. And the winners of this was a company called 16-Bit from Canada. And they had a mean absolute difference of 4.3 months compared to radiologists. This was super exciting because this algorithm was achieving radiologist level performance with very high levels of accuracy, potentially allowing for automation of this kind of task, which admittedly is very monotonous. You're basically looking at an atlas, you're flipping back and forth trying to find the right pattern that fits most closely to the hand. And so one of the cool things was 16-Bit. They won the competition. They packaged their algorithm into this browser-based application, really slick. You can insert an image, you can upload it, take a photo with your smartphone, and within seconds, you get a predicted bone age that's going to be highly accurate. But the question is, does AI have common sense? Because what happens if you put in a chest x-ray? Well, it gives you a bone age of 1 year, 1 month. Or flowers, 15 years, 11 months. Or a radiology resident gives a bone age of 1 year and 5 months. Now, even if you're not a radiologist, even if you're not a physician, you can probably tell that it doesn't make any sense to predict the bone age on any of these data inputs. But it's important to realize that most AI in its current form does not have this sort of common sense or semantic awareness of images. It just looks at it as an array of numbers and does essentially complex mathematical calculations. And so it's important to realize that although these models are very good at single tasks, they're sort of like savants in that they're not really good at much else. So it's important to recognize these limitations, especially as we think about clinically deploying these models. Something a little bit more clinically relevant, though, is this concept of stress testing. Like I said in practice, images are not always presented in the optimal way. I can tell you as a radiologist, a lot of times my images come rotated, and so I have to manually unrotate them to interpret them. The contrast and brightness similarly are not optimal, in which case we can adjust these things during the course of medical imaging interpretation, but that's not always the case with these data sets. And so we performed a stress test of this 16-bit algorithm, basically evaluating how does the model perform on images that have been rotated and have different brightness and contrast. And what we found was that if you rotated an image 180 or 270 degrees, you actually have quite a higher degree of error compared to baseline images. So what this means is that if you encounter these images rotated, which we do clinically, well, your predictions might not be reliable. So I think this is another pitfall, especially as we think about clinically using these models, that we have to be aware of the potential for these models to basically give incorrect predictions based on seemingly benign modifications to the images. All right, so moving on to something a little bit more technical is this concept of shortcut learning. So in AI for radiology or any medical imaging, our hope is that we can have a model that does something like this. We take a radiograph and we get to a diagnosis of abnormal versus normal on the basis of the image. But what can happen is there can be a confounding feature that's associated with the normal or abnormal label, and then AI can use that feature to make the correct diagnosis. So essentially making the right diagnosis, but for the wrong reasons. Now, one potential confounding factor that's ubiquitous in x-rays is laterality markers. So if you look at x-rays, oftentimes you see an L or an R to signify, hey, this is the left hand. there's also these technologist initials, basically as a quality control, saying like, hey, technologist with the initials LM took this x-ray, so if you have any problems, you got to talk to that person. Now, we did a set of experiments where we retrained 3 separate convolutional neural network classifiers trained with the mirror data set of extremity x-rays for normal versus abnormal prediction. The first was with the normal images, just taken at face value. The second was where we placed black boxes over the laterality labels and technologist initial labels. And the third was where we extracted these labels and trained a model solely on those labels themselves. So basically we said, hey, can you predict if there's normal or abnormal from these 3 respective images? And what we found was on the original model, on the original images, we had an area under the curve of 0.84, so not bad. You know, it's not perfect, but you know, it's nothing to scoff at. When we took the labels themselves, so just the R's, just the L's, and trained a model, what was shocking was we had an AUC of 0.64, so greater than chance accuracy. So what this meant was there appeared to be some signal there in these letters that were associated with the normal and abnormal. And then when we put a black box over those labels, well, we found that there was a slight increase in performance to an AUC of 0.86. Now, you know, you might be asking yourself, well, what's going on? Well, when we look at the first model and these heat maps that show the parts of the images that are emphasized by the CNN deep learning model for making this decision, we found that in 89% of images, the model actually was focusing on these labels. So that's clearly a problem, right? Because we saw that with these labels themselves, well, they had signal. So it appeared that the model was doing shortcut learning. Now, when we put the black box over these labels, well, we were able not only to improve the AUC and performance, but actually redirect the emphasis over to the relevant parts of the hand and wrist. Now, one thing to note is these laterality markers are ubiquitous. I mean, you see them on mammograms. We've shown this phenomenon in breast imaging. You see them on chest x-rays. So I think that this is one of those things that's going to be really challenging because we're not going to get away from them. They're just standard parts of medical imaging quality control. And so I think that it's just important to keep in mind that this is a potential failure mode for your models, even if the performance seems to be quite good. All right, so something a little bit more technical is explainability. And so explainability is the idea of how do we make these deep learning models less of a black box and try to understand what's going on. Why is it making a decision? What is it looking at? And so in the literature, both in the orthopedics and radiology literature, a lot of you have probably seen images like this with these heat maps that show areas that are emphasized by the algorithm to make its predictions. And these are really quite nice. They look really pretty. They often confirm our suspicions. Let's say in these cases for hip osteoarthritis, we're looking at joint space narrowing, subchondral sclerosis. We can look for osteophytes. And you know, I think one thing though to note is that these heat map techniques, they're approximations of the mathematical processes occurring in the deep learning models, but they're not perfect. And there's a number of different methods. And so one question that we had was, well, can we trust them since they are approximations of these mathematical processes? They make certain assumptions. And so what we did was basically a trustworthiness test of a number of different saliency map techniques, looking at things like localization. I think this is probably the most intuitive test that we did, basically asking, do these heat maps actually light up or show the areas of abnormality that a radiologist might? So in the middle, we have bounding boxes placed by radiologists. On the right, we have a heat map, basically saying how often do these overlap? And essentially what we found was that if we look at the human, which is the second box here, this is a panel of 3 musculoskeletal radiologists. The AUPRC was significantly higher than for any other saliency method. And in total, we looked at 6 different ones. So what this means is that, you know, although these heat maps sometimes show the area of abnormality, there's still a far cry from actually matching what a human might do. And so I think the explainability piece is still being worked out. We're finding that these saliency maps are not super trustworthy for a number of reasons. One thing that I do want to say that's down the pipeline in a paper we recently published is this new type of algorithm called vision transformers. So the mainstay of deep learning has been the convolutional neural network. And we see things like this. For the heat map, you know, it's it's kind of helpful. This is a mid-diaphyseal fracture of the humerus. We can see that on the input image, and we see that the heat map, it does light it up, but it's almost like someone threw a bucket of paint and just kind of covered the entire arm. So it's questionable about how useful this actually is. But when we look at transformers, which I won't go into too much into the nitty-gritty, but basically it's a fundamentally different type of vision mechanism. Well, we find that with these attention maps, we find more tightly localized abnormality detection, in this case, to the fracture. And so this paper that we recently published in Radiology Artificial Intelligence, it's a preliminary evaluation, but our results suggest that these vision transformers do have not only performance improvements potentially, but also explainability improvements. I think that's something to keep in mind, that we may have some solutions coming down the pipeline. The last and final pitfall I want to talk about is bias. And so although AI has a lot of potential in high performance comparable to experts, unfortunately what we found in the computer vision literature is that imbalanced demographic representations, let's say of male or female, in medical imaging data sets produces bias classifiers. In this case, this was looking at chest x-rays. Basically, if you train a model with only male images, well, you're going to perform better on males than on females, thereby potentially perpetuating healthcare disparities. Now, some people, like Dr. Hugh Harvey, who's a radiologist in the space, said, well, that makes sense if you have chest x-rays, you can see breast tissue, but what about areas where the anatomical differences between males and females isn't as obvious? And so we sought out to answer that question for knee osteoarthritis. Take a guess which one's male and female. I don't know about you, even as a fellowship trained musculoskeletal radiologist, I can't tell which of these is male or female. And in fact, the one on the left is female, and the one on the right is male. But nonetheless, we reproduced similar experiments where we trained algorithms on only male and only female images, and we tested them on both sexes to evaluate, is there bias? And what we found was that yes, there was bias. And when we look at the heat maps, it's interesting. When you look at let's say the male model and a model trained on both males and females, on the male images, we actually see emphasis of the knee region of joint space narrowing. But on the female model that was trained only with females, when it encounters a male knee, the heat maps look less reassuring. And similarly for the female images. So what this indicates or suggests is that the deep learning models are picking up on anatomical details related to sex, so male and female, that may be beyond human vision, but nonetheless are being used to calibrate their predictions. Going back to the age application from 16-bit, it was a really, really cool development. But one of the issues was that this algorithm was developed on images only from California at Stanford and in Colorado, which are predominantly white populations, pretty high socioeconomic status. So the question we had was, is this model going to be biased against kids who are not white, kids who are from other parts of the country? So we recently published this paper in our premier journal, Radiology, evaluating just that. Is there bias in these deep learning models? Again, the problem was the models are trained on these populations. So we tested it on a different set of data sets from Children's Hospital in LA, intentionally curated to be diverse with representation across sexes, races, ages, and BMI. And what we found, in short, was that there were clinically significant biases favoring males, favoring kids in the intermediate age and sexual maturity groups, and favoring white children. And so even here, for something that seems pretty cut and dry like bone age, we can have biases that may not be reflected in the performance itself. And so one of the other things is when we try to look into, was the model systematically underdiagnosing or overdiagnosing bone age predictions? Well, when we look at it based on race, there doesn't really seem to be any specific predilection, which is problematic because if we're trying to change or solve this problem, well, it's hard because it doesn't seem to be one way or another that the model tends to predict. And one thing to keep in mind, this was a paper performed by some friends of mine out of Emory and a number of other centers, where they showed that AI models can predict a patient's race based on x-rays, including bone age. And so the idea is that, well, maybe there's bias because these algorithms can predict race, they can predict sex, they can predict these demographics and use them to calibrate their findings. So this is an area of great importance from a societal and health standpoint, and also from a technical standpoint, I think we've got our work cut out for ourselves, but it's nonetheless something that we're actively and other groups are actively working in. So with that, I want to end with some considerations for the practicing radiologist or surgeon in light of these pitfalls. I think the first is know the reality, but use it accordingly. We have to know that AI, it's got tremendous potential. I mean, we're seeing expert level performance for a variety of tasks, but we have to also recognize that those results are often reported in laboratory settings. When we go to the real world and try it out, it might not be quite perfect. There's these pitfalls, whether it's poor generalizability or bias or poor explainability. So it's just important to temper our expectations appropriately. The second is trust but verify. You know, if a vendor says, hey, we've got an algorithm that's 100% accuracy, well, you might want to say it sounds really good, but let me try it out in my population. Let me test it out first. So it's just about being a savvy consumer, and ultimately so that we can take the best care of our patients that we can. Another thing I think is, you know, learning basic AI concepts can go a long way. Not all of us are going to do research in AI. Not all of us are going to get into the technical nitty gritty. But I think even if you're a practicing surgeon or let's say implant rep, well, if you're going to be interfacing with these technologies, maybe some companies or partners, it helps to learn some of the lingo and some of the concepts. And so articles like this, which are written specifically for radiologists and physicians, are a really nice introductory way of learning these different concepts. And finally, what I've come to realize is that AI is really hard. This is a cartoon by my friend Felipe Kitamura. He's a radiologist in Brazil. The y-axis is fear that AI will replace his job. X-axis is time. For him, his fear started out very high that AI would replace him. But the first day he trained his first deep learning model, that fear dropped to essentially zero. And I've come to believe a similar thing. I think that AI has tremendous potential. I think that it's going to change how we practice medicine. But I also think because of these pitfalls, well, it's probably not going to replace my job anytime soon. And there's a lot of work to be done to make it even better. So some take-home points. The first is that AI has tremendous potential to improve radiology. The second is that pitfalls abound in every stage of AI development and deployment. So it's really important to recognize these and try to address them, hopefully proactively, and if not, expeditiously in a retrospective fashion. And finally, awareness of and addressing these pitfalls is critical to allow AI to reach its potential. If we don't address these, at best, these algorithms are just not going to get adopted because no one's going to trust them. And at worst, they're going to be deployed unknowingly and potentially hurt patients. So I think it's important that we are aware of them and not look at them as doom and gloom, but say, hey, we're going to be aware of the problem. Now we can start addressing it, fixing it. So I want to acknowledge just the numerous people I've worked with. These are just some of the folks I've worked with over the years on these and other projects. There are countless others, but just giving a shout out to some of them. And again, please be on the lookout for the Yumi Center. We just launched in September. We've got a lot of exciting things in the mix. We're looking to work with people across academia, clinical world, as well as in industry. One other shout out, I do host a podcast for the RSNA, for the Radiology AI Journal. You can find it on Spotify or wherever you get podcasts. And I invite you to stay in touch. Here's my email address. You can follow us on Twitter. Check out our website at intelligentimaging.org. With that, I'd love to answer any questions and appreciate your time.
Thanks so much, Paul. This is a super important work. And personally, I was surprised by how dramatic some of these biasing findings were. Right, like the differences you showed between the male and the female heat maps for the knee osteoarthritis. I mean, we tend to think of our AI as being able to be sort of as good as the data it's trained on and learning, you know, to perform similarly to a human. But actually, I think these findings show that sometimes it's looking, we don't really understand what it's looking for, and you know the results and the problems that can arise from that fact can be pretty surprising. So yeah, that was interesting. So yeah, so some of the questions we're getting here, I'll sort of mix the stuff I got from the audience with some of my thoughts. So the first question, which is better, more data or cleaner data, right? Going back to the first part of your talk. And more importantly, how can we quantify this? How can we find a way to quantify the balance between those two considerations?
Yeah, that's a really interesting question because if you look at the computer vision literature, what they say is, well, let's back up for a second. So in general, right, as you and I talked about, Moshe, deep learning is very data hungry, right? Part of the reason why deep learning didn't take off until 2012 was we didn't have the ImageNet data set. That took just countless hours of Amazon Mechanical Turk workers just painstakingly assembling images. And in radiology, we didn't really have our ImageNet moment until 2017 when we had this data set of 100,000 X-rays. So on one hand, you could say more data is better. And when in the computer vision literature, they've actually looked at ImageNet and tried to look at how much noise is there in the labels, meaning how inaccurate are they. They find that actually deep learning models can account for noise and imperfections in the data labels with increased data size. Now, I am a little skeptical because I think that if we take it to an extreme, if we have a billion images and they're all incorrect, I don't think we're ever going to overcome that. So I think that it's got to be a mix. I think in medical imaging also, these are different than looking at pictures of cats and dogs. We're trying to find pretty subtle things, let's say like grade 1 through 4 osteoarthritis. We're trying to predict the volume of like a bleed in, the head. Those are labels that I think, the sensitivity of a model to inaccuracies in the labels, I don't know if it's going to scale in the same way. It's just like, hey, this is a labeled a dog, but it's actually a cat. So I think that if you had to ask me which is better, honestly, I think I would probably say more data because we can always go back and relabel images. But I think you can still do a lot with relatively small data sets if they're high quality. We talked about transfer learning before, taking a model that's been trained on one data set, basically fine tuning it on another. Well, I think that, if I had the choice of like 1,000 X-rays, which is relatively small, but with really high quality labels, I might take that over 100,000 with like, pretty bad labels, just because I know that transfer learning will work pretty well. To answer your question about how do we quantify this, well, I think we can do empirical experiments like what they've done for the general computer vision literature, where we have a data set, kind of randomly flip-flop labels, and then evaluate how does performance change as a function of data set size and noise. That has not been done, to my knowledge, in any robust way in medical imaging. So I think it's a great idea for research. It might be something to, for any researchers out there to evaluate. So I think it's a really fantastic idea. But yeah, I think the jury's still out though on what to do exactly. So it's really a ripe area for study.
Yeah, interesting. I think quantifying that has probably got to be empirical, right? Because even each data set and each application might behave completely differently. I mean, one of the things we try to do sometimes is sort of late in the game when we're trying to go from, say, 99% to 99.3%, then we'll start focusing on, cleaning up the data and really showing very clean images at the expense of quantity. But yeah, at the beginning, as you said, the models do tend to figure out how to ignore the noise in their data sets. So yeah, it's a challenge that's not going to go away anytime soon. Apropos Amazon, also we had some curiosity here. What can you tell about, if anything, about your work with Amazon, and where do you think Amazon is trying to go as a company with medical imaging?
Yeah, for sure. So, I've had the good fortune to work with a couple groups at Amazon. The first was a group at Amazon Go, or at least formerly Amazon Go in Israel. This is one of my collaborators at Hopkins, Dr. Greg Hager, who's actually an Amazon faculty scholar there now. And basically, they were trying to figure out ways of detecting out of distribution samples. And they were using medical imaging as a use case, I think more as because Greg's experience was in medical imaging. So Greg brought me on, and I think there's certainly these hardcore research groups trying to answer these kind of, technical computer vision questions. Because out of distribution detection, it's applicable in medicine, but it's also applicable in, self-driving cars. It's applicable in like Amazon, the Amazon stores where you can just go in and pick up your items and walk out. So that's one area they're interested in. But the most recent collaboration has been with a group led by a guy named Chris Hafey. And it's been officially launched, so we can talk about it now. It's called Imaging Health Lake. And basically, it is a next generation infrastructure for medical imaging in the cloud that's taking advantage of everything AWS has currently, but making it specific for medical imaging. So everything from research, so let's say curating images for machine learning, but also clinical work, saying, hey, radiologists, you need your images at this speed. We can make it this much faster and cheaper to store them, transmit it faster. So what our group was part of a beta development group where we're trying to build applications on top of this new type of infrastructure, showcase what it can do, and ultimately make our lives better. We think that what my experience has been is that a lot of the infrastructures we use, they kind of lag, several years behind the latest and greatest. I think that we can really make a lot of dents, not just in machine learning, but also in clinical workflows by leveraging, AWS and their technologies. So, we'll be presenting some demos of some of our work with them at the RSNA meeting this December in Chicago. And we'll look forward to sharing that with the community at large in the coming months. So yeah, there's a lot of cool stuff at Amazon, infrastructure, research, and everything in between.
Yeah, I think probably Google is also trying to go in a similar direction, right? They'd also like to eventually be, the cloud for medical imaging, which has its own requirements. And then the AI is sort of just an add-on or a sweetener to that, right? Once you are the cloud, then yeah, you tap into all this data, and then that's going to be the enabler for AI. I guess we have time for one more question. Going back to the general themes of your talk. So, role of the radiologist in 10 or 15 years from today, right? What's going to change? What will stay the same? What do you think? I mean, I can say that we as a company, I mean, as challenging and as important it is for us to recruit the great engineers, but recruiting great radiologists is even more important for us. So from my vantage point as, the AI industry guy, we just need more and more help for radiologists. But interesting to hear your perspective as a radiologist. What do you think the role of the job of a radiologist or the role will look like in 10 or 15 years from now?
Yeah, I think in 10 to 15 years, my personal opinion is I think in 10 years, radiology will look similar in terms of what we do each day, which is interpreting images. But I think that the tools that we interface with will make it different kind of on a practical level. For instance, right now we're already using algorithms to triage potentially emergent studies.
Yeah.
I think that's just going to be taken to the next level incrementally each year, where not only will we triage for head bleeds or pulmonary emboli, it might be for every type of diagnosis. I think that certain things that I do on a regular basis, like measure tumors or maybe measure angles, I predict that, well, radiologists will still do that, but it'll be automated and they can look at it, verify it, and then insert it into their report. I think on a longer term scale, I think that the role of the radiologist will change pretty drastically from a fundamental level where, we may not just be sort of interpreters of images from a qualitative standpoint, but start incorporating quantitative measurements where we become sort of like internists, where internists look at lab values, right? They have to look at the lab values of vital signs. They have to integrate it all and make a diagnosis. Well, medical imaging with deep learning, we can do things like quantifying muscle volume. We can look at the volumes of organs. We can look at the densities of certain organs, certain tissues. And I think that that's going to be part of the radiologist, where we're going to get sort of like lab values from the images, and it's going to be part of our reports, and it'll be part of our diagnoses. So rather than just saying, hey, we see that the muscles are really small, they're atrophied, they look like they're fatty replaced, it'll be like, yes, we see that, but also this is the percentage of fatty infiltration of these muscles. This is the percentile of the muscle bulk for this patient's age and sex and, demographics. And based on that, we can diagnose that you are, well, deconditioned, and you're deconditioned to this grade. And so that's just, one example from an MSK kind of standpoint. But that's where I think it's going to be different, where we're going to inherently now have quantitative imaging measures. That to me is one of the most exciting things, because we'll have a level of precision that we've never had before in medical imaging.
Yeah, and that's going to require reproducible and standardized tools, right? Just like now in a blood test, right? It's unambiguous what these numbers are going to be, right? You can do the analysis anywhere in the world and it will come out the same. So I think AI, to get to the point where, you know, you don't just have an image or a CT, but you have all these biomarkers, all these quantitative measurements. You know, we're going to need to get to the point where those measurements are reproducible, and the AI sort of is standardized to the point where, you know, it's not going to be ambiguous. You know, if you would run it through, I don't know if that's going to be because, you know, one particular algorithm or one particular model is going to be, you know, the industry standard for a particular measure, or if we do get to the point where the whole community has sort of enough data and we have enough research on how these measures should be extracted and how these models should be trained, that this actually becomes reproducible and becomes quantitative.
Totally,
Yeah.
absolutely. Couldn't agree more.
Fascinating. So thank you so much, Paul, again. Everybody in the audience, thank you for participating again. And the recording here is going to be available very soon on our website, on LinkedIn and YouTube. Yeah, that's it for today. So thanks so much for being our guest today, Paul. And we hope to hear further from you going forward in the future.
Absolutely. Thanks so much for having me, and really appreciate the opportunity.
Pleasure. Okay. Have a good day. Thank you.
All right. Have a good day, everyone.
Bye now.